Dr. Jamie Koufman, and this is Dr. Koufman's Acid Reflux Hour. Today I'm going to talk about interesting cases, but they're really teaching tales. And I think what I really want to do more than anything is establish the relationship between silent acid reflux and respiratory diseases. The new title, the book that's coming out, it's not ready yet, it's not done, is a respiratory reflux, how silent reflux causes diseases. And you can see that certainly the throat and the lung, but so the sinuses, nose, station tubes, any part of the respiratory system. So for you who know the term laryngopharyngeal reflux, I came up with that term in '87 because I didn't want to say GERD. My patients didn't have heartburn or indigestion. They had throat symptoms, voice symptoms, and so on, breathing symptoms. And so that term is actually done well for a long time, but what it really says is reflux into the larynx and pharynx. But what about those other parts? What about the respiratory parts? So the new term respiratory reflux means reflux into the respiratory system. And I believe it's a pinnacle term. It is a term that will survive. I would hope that the term GERD will go away because it's always been a wastebasket term, and we'll call patients who have heartburn and indigestion people who have esophageal reflux, and people who have respiratory symptoms respiratory reflux, and some people obviously have both. So I coined the term LPR, I'm coining the term respiratory reflux, and I think that's what you have, and that's why you're here. Why am I an expert in this? I've been looking at this question seriously as an academic with a state-of-the-art, by the way, state-of-the-art is no longer here. I had custom reflux testing catheters made with high-quality sensors in the throat and the esophagus. There's no technology available today. So if you say, oh, I want to go have a diagnosis, so the gastroenterologist has a Bravo test, which is useless. It tells you what's happening in the distal esophagus. It has impedance, a pH testing, which is useless. I have tons of patients with respiratory reflux who were told they didn't have reflux. TIs have no test for respiratory reflux, and in fact they don't know anything about respiratory reflux. How do I know that? One of the opinion leaders in the field saw a recent consultee. I did a consult on a man who saw this big shot, and the big shot did the GI testing and said you don't have reflux. The man has postnasal drip, chronic throat bleeding, chronic cough, everything, including shortness of breath, and certainly, without question, based on his profile alone, has a 99% chance of it being respiratory reflux and respiratory reflux only. Now, why does the GI not know? They don't have any tests, and they have a conflict of interest, and it's going to cost them a lot of money. If the Jamie Koufman model is right, then the GI, looking down the esophagus is not how you diagnose reflux. More than 80% of people who have respiratory reflux have normal esophageal exams. And by the way, I'm going to skip ahead to one of the questions. My blog, jamiekoufman.com, was written for you. So I get questions week after week after week after week about hiatal hernia. There's an article, type in hiatal hernia and up it'll pop. The vast majority of people have small hiatal hernias. They have no clinical significance. So they don't need operation. They don't mean you've got terrible lifelong reflux. They are clinically insignificant. Now, to get to the cases, I wanted to begin by a case that is a very simple case. It's 29-year-old barista from Brooklyn, a lovely young woman. Was very athletic, used to run, 5Ks. But anyway, for the last 2 years, she'd had shortness of breath on exertion, meaning coming up out of the subway into my office, there's a 32-step, it's a long consecutive number of steps. She couldn't make it up to 32 steps up to my office out of the subway without a real shortness of breath. So I diagnosed her reflux. She had pH testing. The name of the test I used was a 24-hour ambulatory, meaning you go around, pH simultaneous esophageal and pharyngeal reflux testing, and hers was terrible. Okay, she had reflux basically sitting in her throat almost all night. So I put her on an anti-reflux program. If you want to know, go on the blog. You can type in reflux detox. You can type in intermittent fast. You can type in alkaline water, gum chewing, a chamomile, ginger, anything almost. It's in there. That blog's been written now for a number of years. So anyway, I put her on my program. I want her to sleep, stop eating at 3 o'clock. She went to bed at 11 and sleep on an incline of at least 45 degrees. This woman's been miserable for 2 years, hasn't been able to exercise, and I got a phone call. I slept in a chair for 5 nights and my breathing is fine. Now, she did more than just sleep in the chair. But it's a pretty dramatic, things heal. And she just stopped her reflux cold, and her shortness of breath went away. Now, the shortness of breath is tricky. And the reason it's tricky is because they have normal lung function and they have normal chest x-rays. So why do they have shortness of breath? Is it microaspiration and some of the alveoli have been knocked out? And I don't think so. I think it's vaguely mediated. The vagus nerve, if you haven't read it, 3-part article on the vagus nerve. The vagus nerve runs the respiratory system, the digestive system, and the cardiovascular system. So one of the things I've discovered, and I present it often, and Koufman's sign, is that the inability to just comfort in taking a full breath in. That a lot of people describe as shortness of breath is unique to respiratory reflux in my experience. So there's no other problem that causes this to my knowledge. And if you have COPD and you have trouble taking a full breath in, you got reflux. So that brings me to my next case. Patient came to see me with COPD. He's a lovely man in his late 60s. He was having a lot of trouble breathing with oxygen. The short trip from my waiting room into my office for examination was difficult for him. And without the details of his reflux testing, he was in what I call the championship division, and I put him on a very strict protocol. Within 2 months, he was not oxygen dependent except part of the time. And 2 months later, with only intermittent oxygen or no oxygen, he was in his car on his way to Florida to watch the Mets spring training. So he quit smoking 25 years ago, and he had progressive COPD. So I'm saying to you, the cause is respiratory reflux. No heartburn, no indigestion, silent, nighttime respiratory reflux. Cannot drink alcohol, cannot eat too late, should sleep on an incline. It's a lot of things people, and this guy had a life-threatening disease, right? He was going to die of COPD. It was transformative. So not only do we prevent progression of disease, but he actually improved substantially enough to not be oxygen dependent. So COPD, people ask me, COPD in a non-smoker is caused by reflux. 100% of the time, no, nothing's 100. 95. So COPD. Now the next one is related. It's a younger man with chronic bronchitis for 4 years. He's coughing almost continuously, and he's being seen at a major medical school in Boston with a famous name, and a major institution in Denver which deals with respiratory diseases, and he's flying back and forth. And he's been doing this for 2 or 3 years. And the big problem is not only does he have bronchitis and cough, he's got a problem. He's on the plane like this. What's he coughing up? He's coughing up blood. So here's a guy who's been coughing up blood for 3 years. Okay? So how he ended up in my office, I don't know. His reflux testing was prize-winning. In this case, I sent him straight to the surgeon. Now, he had to do other things too. He couldn't eat late, he couldn't drink alcohol. I put him on medication. I did everything, but I also sent him straight away to the surgeon for reflux. laparoscopic fundoplication, 300 degrees surgery. It's the only thing that's helpful. All the other things you hear about, the links and this endocinch and TIF and all of them, they're money makers, and none of them are real reflux treatment. Okay, there's only one cure, real cure for reflux. One: diet and lifestyle. Period. Okay. So if you had a surgery and you go out to steakhouses late and you're a little bit alcoholic and you get home at 11 o'clock with a full stomach, doesn't matter whether you've had surgery or not by the best surgeon, you get reflux all night. So anyway, this guy's bronchitis and coughing up blood was gone in 6 weeks. G-O-N-E, gone. At five-year follow-up, he was well. Okay? So we have chronic bronchitis. Again, both non-smokers. I consider the COPD guy quit 25 years ago. That's a non-smoker. So if someone gets cancer of the larynx 25 years later and quit smoking 25 years before, the cause is acid reflux. So the next case I'm going to tell you is actually about a vocal cord cancer. It was about a 45-year-old man from Statesville. He came to see me with a small vocal fold lesion. I was one of the first laser surgeons. I had the third CO2 laser in the United States for working on vocal cords in '78. It was just reclassified by the FDA. So I used my laser and I took the little thing off, and sure enough, it came back as a small vocal cord cancer. And they didn't heal very well. And this is before I really understood reflux, by the way. And he had granulation tissue. It's called granuloma, granulation. It took 6 months to heal. And then the next year he came back with another cancer on the opposite side, and I took it off and it healed fine. And then he came back again. I don't remember. This is a published case, but I don't remember the details right now. It's in my trialogic thesis. With a third cancer, then a fourth cancer, and then a fifth cancer over the course of about 5 or 6 years. And some of them healed well and some of them granulated for a long time. That's when I had reflux testing, and I reflux tested this guy, and his reflux was off the wall. I sent him for surgery because I didn't know what else to do, but other things. No eating late, no alcohol, and guy never made a cancer again. So lifetime non-smoker, 5 cancers in 5 or 6 years of the vocal cords. All, by the way, with reflux findings, when you look now back at the reflux, at the examination. And it all stopped when his reflux came under control. So reflux causes a cancer of the larynx, cancer of the throat, cancer of the esophagus, and cancer of the lung. I've said this before and people laugh. In my opinion, we're talking about airway, respiratory cancers. You can get cancer without smoking. But not without reflux. The reflux is probably the sine qua non. In fact, we've done some work looking at pepsin in cell cultures and in laryngeal cell cultures. The pepsin upregulates all the markers for squamous cell carcinoma. So pepsin, we think, is the cause of cancer, activated obviously by Ares. Now, I'm going to do a show on Barrett's probably next time. And but I want to make some comments that Barrett's is not the cause of cancer, reflux the cause of cancer, and that Barrett's is actually even reversible. Now, I want to tell 2 more interesting cases. Let's see how they are time-wise. Yep, doing fine. The most important case, I have 15 questions today about ears. So a 29-year-old computer programmer from Washington came to see me in New York, and this guy was wired. He was off the wall. He was adamant. He said, I have hearing loss and ear pain and tinnitus, and it's reflux caused. I've seen like 19 doctors. They've all told me I'm crazy. It's reflux. Fix it. So I examined him, and when I examined him, the eustachian tubes are in the pharynx is very long. The pharynx is the tube, right? The nasopharynx is the nose pharynx behind the nose. Okay? And that's where the eustachian tubes are. They're prominent. You can see them. They look very much like little volcanoes with the crater in. So the eustachian tubes were There was a completely inflamed. There was cobblestoning, extra mucus, redness, and actually significant swelling compressing the eustachian tubes. So sure enough, I put him on an anti-reflux program, and in 3 months follow-up, his ear symptoms had disappeared. Now, I didn't know this because he came about relatively late in my career. It was like the last shoe dropping. Yes, it causes sinus problems. Yes, it causes asthma. Yes, it causes shortness of breath. But I wasn't sure about the ear until this guy. Meanwhile, when people started coming in with sinus symptoms, I said, do you have any ear symptoms as well? And they very often would offer, I have ear blockage, eustachian tube problems, hearing loss. And so it turns out that it's probable that a reflux affects about 10%, 5 or 10%, significantly affects 5 or 10% of people with respiratory reflux. And it's a secondary symptom, and they don't relate it necessarily to their reflux. So yeah, it can cause hearing loss, problems with pressure, equilibration, ear pain, and tinnitus. Now, most common cause of tinnitus is high frequency hearing loss, but for you refluxers, respiratory refluxers, there's hope for eradication of those symptoms with effective reflux treatment. Now, I wanted to tell one more case, but we're out of time, but I want to mention the fact that a patient came to see me who had an autoimmune disease, and it was severe. He was young, and he was talking about all kinds of radical treatments, and thought he was going to die. He was 21 years old, and he had no airway and a tracheotomy in place. So he came to see me, and I said, you got terrible reflux. We fixed his reflux, and I had his tracheotomy out months later. So he had tracheotomy in for 2 years with narrowing of his airway due to the combination of relapsing polychondritis and reflux. So reflux is an accelerant for any kind of airway or lung disease. And it's silent nocturnal respiratory reflux. The symptoms: postnasal drip, too much mucus, chronic throat clearing, sensation of a lump in the throat, difficulty swallowing, and shortness of breath. As it turns out, I'm studying shortness of breath now, and when I have a sufficient, in fact, I wanted to do 100 consecutive cases, but it turns out that things have changed over the course of the last decade or so. I'm not sure exactly, but I think shortness of breath is going to turn out to be the third or fourth symptom of respiratory reflux, and that heartburn is at the bottom. It's almost none of our patients have heartburn. So anyway, I want to get to some questions, and these are doozy questions that require explanation. So this has been asked over and over and over again, and I've sort of not addressed it fully. When and how do I taper my reflux medication? So let's assume that you're on famotidine. Let's forget about proton pump inhibitors. That's the next question. So you know proton pump inhibitors are omeprazole, Prilosec, Nexium. They all are terrible medicines. I stopped using them completely in 2014. There are 4 blog posts on it. Long-term use increases your risk of cancer. There's a lot of reasons why you shouldn't take them. PPIs cure 0% of people. They cure. Now, but let's say someone's been on my program. It's 6 months out. They don't have reflux. The cough's gone. The other symptoms are gone. They're behaving themselves. They think maybe I don't need my medicine anymore. And they're taking famotidine 1 before breakfast, 1 before dinner, and 2 before bed. 40 milligrams the nighttime dose, 20-20-40. And they're taking alginates such as Gaviscon Advance, or the 2 other ones that are popular are Reflux Raft and Reflux Gourmet. I still tell you that by far the only one that's been studied and the least expensive is Reflux, is Gaviscon Advance. And make sure it's Gaviscon Advance, not extra strength or whatever. But all the products are good and all the products work, and some taste better than others. By the way, people have asked me a lot about that. That is a cat called the Dude. And when I say office, he comes and he runs in that chair and he sleeps most of my time in my office when I'm writing. So the dude, not going to say anything, dude asleep. I recommend that you taper 1 dose per week or 1 dose per month, starting at the bottom. So you say, I'm doing really well, I'm not going to take the breakfast one. So a week later, you stop taking the dinner time one. And then a week later, instead of taking 2 at night, you take 1 at night. And a week later, you take none. Now, when you're off medication, you should never think you're home free. In fact, if you have a pocketbook or a backpack, you should carry some famotidine, some Pepsi. Say you're going out to dinner a little late. Take 1 before you go. Take 2 when you get home. Take the Gaviscon Advance or whatever, the Alginate, and sleep on an incline. You should never have gone out to dinner at 7:30 if you're planning on going to bed at that hour. You know, what's the right hour? 3-4 hours. For older people, 5 if you really want to not have reflux. Turns out that's the truth. Sorry. That's the way it is. I eat about 5 o'clock and I usually go to bed around midnight. Don't have reflux. So the same thing is true of other reflux medications. They should be stopped basically from the bottom up, 1 dose at a time. And for people who are on medicines for a neurogenic, let's just say neurogenic cough, and let's just say you're on 4 times a day. Again, this is 1 month at a time. Stop the morning dose. Don't decrease. Just stop it. Stop it. Stop it. Stop it. And so it'll take 4 months to get off. If the cough comes back, then you need to go back on. Now, this is one that I'm going to have to, every time I stop taking my Prilosec, my reflux gets 10 times worse. What can I do? All right? Stop eating 5 hours before you go to bed. Sleep on an incline. No alcohol. Nothing out of a bottle or a can. Have a low-fat, low-acid diet. See Reflux Detox. Type it in. Chew gum after each time you eat. Alkaline water. Spray Gaviscon or other alginate and the famotidine 80 milligrams a day. And you should do that strictly with no interruption or cheating for a minimum of 4 weeks. That's the starting point. Because things heal. I mean, unless you're immunocompromised, I mean, if you have a cut or something that's in some little body part that's inflamed, if you stop banging it around, we're not talking here about hips and knees, we're talking about reflux. If you can stop it, it'll heal. So the idea Prilosec would heal you and cause you to better, it basically improves heartburn in 57% of heartburn sufferers. Prilosec, let me say this 50 times, cures no one. 0%. Okay? And long-term use of Prilosec is associated with an increased risk, not decreased, increased risk of esophageal cancer. Read the post. Now, rebound hyperacidity occurs in about 1/3 of people. That means when they stop taking a PPI, their reflux is worse than it ever was, and it's a big problem. So I recommend going on the famotidine, going on the detox program, taking alginate after each meal, chewing gum after every time you eat or suck on a hard candy. Big trick, by the way, they're all patient tips, so we study them. Chewing gum made my heartburn go away. So we said, well, how can that work? Well, you make more saliva, more bicarbonate, and you swallow a lot more. And so it's very good for combating reflux after eating. We took a refluxer and fed him and put a pH probe in and waited. He started refluxing. We let him chew gum, went away. Reflux. He started a reflux episode again, chew gum, went away. So there's a program that is a big program. It's not a one-piece program. And it's not a program in which DGL is important. It'll never be important. It's not a program in which some other better medicine will work. So the idea that and I want to make a comment. Many of your questions are about specific or individual possible therapeutic items. You need an entire anti-reflux program to get well, and that's the starting point. So, I get questions like, well, I've been taking your diet and my reflux is not better, and so it goes on and it goes on. And I get questions about all the specifics every day. So, no links to Magnus, bad idea. Tiff, bad idea. There's nothing that gastroenterologists can do to fix your reflux. All they want to do pretty much is give you a pill. Won't work. So that brings me to my next question. I don't read it exactly rightly, but it says, she wanted to send me a direct message. But her question is, when I say do not go to GI doctors, shouldn't I at least be getting diagnosis of hernias, ulcers, motility issues, etc., to figure out what the actual issue is? If you have respiratory reflux, and I mean this sadly, you don't have a doctor. There isn't one. The GI has been looking and pretending that heartburn and indigestion and the esophagus is where reflux is. But for every one of those, there are 10 people with respiratory reflux who have silent nighttime respiratory reflux. Read the article SNOR, S-N-O-R-R. Okay? They don't know anything about it. They have no test for it. They're terrified. They're terrified. So we know because everyone who comes to see me has seen GIs. And when I say things like, if you have respiratory reflux, seeing a gastroenterologist would be better off talking to a tree. You'd think I'd get some blowback from someone, but I never have. And the reason is GIs don't have any tests or treatments for respiratory reflux. I mean, there may be a rare bird out there who's got some information, applied it and learned and moved forward, but it's not the GI way. Problem is the GI is the go-to doctor for reflux. So what's the poor ENT doctor to do or the poor lung doctor to do? They don't have, not in their curriculum. So this is a black hole, and he'll explain to you why. Here's the respiratory system, and here's the digestive system. And up here is the throat, which is the digestive system and respiratory system, right? You swallow through there, you breathe through there, you reflux through. So over here you got pulmonologists and maybe a gastroenterologist and otolaryngologist. But the system is one system. So if you pretend that this system is a discrete problem to be solved, then you're never going to get it right, because they're always connected. And by the way, that doesn't even include the vagus. Remember, inability, difficulty taking a full breath in. They all have normal chest x-rays, they all have normal pulmonary chest. It's vaguely mediated. So the reason why all this has happened this way is because the specialties have divided up a unit that functions as a single unit. The aerodigestive tract includes the respiratory system, the digestive system, and the pharynx is like Grand Central Station. Nothing goes north or south out of there without going through the throat. And there are separate specialties. So I'm otolaryngologist, gastroenterologist, pulmonologist, allergist. I mean, I've been looking at all these things together. Now, I don't want to answer no more questions, but I'm going to conclude this session by telling you what I tell some of my consultees. I broke my hip. The captain of my ship was an orthopedist. If you have respiratory reflux, the captain of your ship is you. You will not find a Jamie Koufman who has good testing and can diagnose you. If you have all the respiratory reflux symptoms, unexplained sinus pressure, facial fullness, mucoperiosteal thickening, read the article on sinus before you have a balloon sinuplasty, a procedure. So all I'm saying is that the medical establishment has not really addressed respiratory reflux, despite the fact that it probably affects 100 million people. So yes, this thing that I'm talking about is the single biggest public health issue in the country. Problem is Nobody wants to address the root cause. Diet and lifestyle. When I was growing up, there was no obesity. One fat guy. When I was growing up, there was no, we didn't even know what sleep apnea was, okay? When I was growing up, we didn't have problems with everybody having shortness of breath and asthma and all of the symptoms that we see today. I mean, it really only has happened during my lifetime. And I didn't see my first McDonald's till, I don't know, the 60s. So I want to finish with, I wish I had answered more. The Prilosec, finish that one. The rebound usually lasts 2 weeks. Take antacids, take extra alginates. Watch your food. Stay away from anything which has like soda, nothing out of a can, no alcohol. I mean, it's got to be full scale attempt to stop the reflux, and chewing gum after every time. Each one of these things adds some layer of protection to get you through the rebound. It does not last forever. Sorry you got it. Sorry you were ever on a proton pump inhibitor. Personally, I think they should be taken off the market. All of them. All 25 million of you who are taking them, how you doing? So anyway, I want to finish this last question that I think is relevant, and that is when I talk about products. First of all, I don't have any associate products. I don't receive money for anybody. When I was in medical school, Eli Lilly wanted to give us beautiful leather doctor bags and stethoscopes, and my class decided not to take them. We felt it was a conflict of interest. Over the course of my career, I never let a single drug rep in my office, not one ever, took me out. So the whole idea, when we put on big programs, we had support from drug companies, but I never had a drug salesman tell me about drugs. So understand, I don't have a horse in this race. So Gaviscon Advance, Reflux Raft, and Reflux Gourmet are all being used by people that consult me. Personally, I would go with the least expensive, assuming you can find it. So I just want to finish with this because it keeps coming up over and over and over again. Read the article on hiatal hernia, okay? I thank you all. This was a sort of all over the place session. And next time I'm going to talk about Barrett's esophagus.